Welcome to Leadership and Culture in Healthcare. My name is Matthew Winn, podcast host, and we are on our 7th series, and we are into clinical leadership. What is clinical leadership? What does it mean? Those who are clinical leaders, what do they tell us about leadership in the healthcare service and the NHS across England, Wales, Scotland, Ireland, etc. So I am delighted that we have an eminent clinical leader from the paramedic world. Andrew Hodge, welcome to the podcast. Why don't you start explaining to people what you do, what's your job, and then we'll dig into a little bit more about how on earth you got to what you do as well.
Thanks, Matthew. So my name is Andrew Hodge, and I'm Director of Paramedicine at North East Ambulance Service, and I've been in post about 2.5 years now, and time has flown, as what we all say when we're enjoying ourselves, and it is challenging, but these are relatively new posts across the UK, and it seems strange to me to say that at one time there was no chief paramedic on a board representing the profession. And as we know, for a long time there's been chief nurse and chief medical officers in hospitals and community trusts. But it's been a really important development for our profession, I think, to have a chief paramedic on a board. So that's my role. And so I suppose the role is to be the voice of the profession, and to start to, I think, put that paramedic pre-hospital lens in some of the decision-making that's happening at our exec management group, and then represent the profession at Trust Board, and all that goes with that. That I think that's in itself been quite big, and I think I can feel a bit of a change happening over the past 2.5 years, where I've got the opportunity to represent us and put things forward and try to steer the direction of travel for our profession. And that's felt a little bit different compared to my previous roles, which have all been good and great experiences, but I've noticed it's been a lot easier, still not easy, but a lot easier at exec level with directors to kind of just be alongside them, shaping it as you go. And I guess the other thing is just the role is part of system leadership as well. So, you try to drive the organisation from within as part of the exec team, as all senior leaders at different levels. We're representing our organisations, our professions, etc. at various system meetings, and it feels really important to be able to do that as well, particularly in our clinical urgent emergency care space, which is a positive thing as well.
So how did you get to be the chief paramedic, the director of Paramedicine, isn't it? In the title. So how did you get there? Give people a flavour of what the kind of career route to achieve that.
Yes, I mean, big surprise.
Not that 2 O levels, no.
I was going to say, I'm a paramedic by background, so there's the first obvious.
Says it on the tin, doesn't it?
Yeah, it does. And I joined actually the NHS in 1995, so it is 30 years ago now. But I haven't just stayed in the ambulance service. I think that's maybe the first key thing that was important to me, and it wasn't deliberate to leave, but looking back, it's been really good to work in different parts of the NHS. So, I grew up professionally as a paramedic, but fairly quickly I went into advanced practice, where, that wasn't a big thing in the ambulance service at the time. So probably in the early 2000s or mid 2000s, actually, I left and went into community services, PCTs as they were at the time, and went into advanced practice. So that was a good thing in developing my clinical practice, but alongside that, I suppose, clinical leadership as well that came with it, as we were starting to lead and help run services on a day-to-day basis, which, is really good development and part of good multi-professional teamwork, which was also really important. But at some point, I found myself in a CCG, and I'll say that almost like that was by accident, but I ended up in patient safety clinical pathways, and serious incident management was what I did in the end. And I suppose it wasn't deliberate, but the roles, the structure kept changing, and I ended up doing different roles.
But that's
And
more, just for those that don't quite get that,
oh,
that's
sorry.
more in kind of clinical governance, kind of is the glue between everything. Are we doing our jobs right? Is that kind of what that role was?
Yeah, and yeah, you're right to point that out. It was in a commissioning organization
Yeah,
rather than a provider,
yeah.
where yes, we were really, you're right, doing all the clinical governance and trying to lead in terms of patient pathways, patient safety, and then, as I said at the end, working on that serious incident agenda and how we learn from incidents and develop openness and transparency. Now, that's nothing to do with being a paramedic. It was just really good experience to be in a different part of the system. But then, I moved on and eventually ended up at Yorkshire Ambulance Service as an advanced practitioner on the front line. But the key thing for me was when I became a consultant paramedic in urgent care. And I still to this day almost feel like that was one of my best roles, because it was that crossroads between clinical practice, leadership, research, education, supervision. It was all of those things that I didn't really know what the role was to begin with, but the more I understood it, the more I wanted to lean into the bits, those parts, and develop, and how that influenced the organisation and tried to shape the organisation in my small way felt really important, actually, and I enjoyed it. I was there for about 10 years. And then about coming up 4 years ago, I went to Mid Yorkshire hospitals. Again, it was a new development, that there weren't really chief AHPs either across the country, and Suzanne Rastrick, who's our chief AHP officer for NHS England, really pushed that agenda, and so an opportunity came up at Mid Yorkshire, and I was their director of paramedicine there. And that wasn't a board role, but that was the head of the professions, which again was great experience, great to work in a multi-professional team, not worked in an acute trust before, very complex organisations. But I couldn't help but come back to the ambulance service 2.5 years ago, when this opportunity came up. So it's been a learning to be on a board has been one of the steepest learning curves I've ever had. I have a feeling it will continue for quite a few more years to come, but it's been really enjoyable so far. And I think we're making great changes and great headway.
That's fascinating. And as you say, a really quite diverse kind of portfolio of jobs to get to this board role where you are. And it's not that you got one to get to this because the role didn't exist. Help people understand then. You talked about the consultant role as a paramedic, and I have to say I thought I knew the NHS pretty well. I probably didn't realise there were consultant paramedics, which is probably my fault for not knowing that. Help people understand the difference between a board director of paramedicine, which is that senior clinical leader, and the consultant role. What differentiates them apart from being on the board?
So you may not have heard of a consultant paramedic, but I'm sure, Matthew, you're aware of nurse consultants, consultant radiographers, etc. It was the same principle. And again, there wasn't very many of those about 10, 15 years ago. And I think the point for the consultant paramedic was to develop the profession and to develop them in that non-medical consultant framework, which was the 4 pillars as I just described. And I think that, so if you're a clinician and you just do clinical practice, it's really enjoyable, but you're probably looking around at the system, frustrated, wanting to change things, but you're unable to, or it's a challenge. If you end up in a non-medical consultant role, you're able to, by your job design, to influence universities, education, and therefore the pipeline of the clinicians coming through. You might even go and teach and see those students and then see them as qualified clinicians years later. You're part of the leadership team. So my role was to be in the operations directorate, be that senior leader, but be alongside operational managers, working with them to influence the decisions that were being made from a clinical lens. You practice clinically, but I think quite importantly, I did get right into, because I enjoyed it. I got into research in a big way, which is the other pillar. And I think what that did was that's started to bring the evidence base to the discussions amongst the management teams so that it's harder to refute, and it's much easier to say this is a direction of travel we should be going down, to influence, as I say, the direction of an organisation. And within your kind of service lines, I think that probably stood me up really well for future roles. But the board level chief paramedic is obviously much more corporate. It's a team effort, isn't it, to take the organisation forward and be part of that team across the wider agenda. But with your focus on the paramedic lens, and with your directorate and your teams who are senior clinicians, and I now in my team have consultant paramedics, deputy director of paramedicine, etc., and advanced paramedics and some nurses as well, as we're multi-professional. And they are doing the same thing I've just described around those 4 pillars and driving forward the agenda for the profession and the organisation. Whereas I suppose at board level now, I think it's, as I said before, actually, it feels much, I was going to say easier. It isn't, is it? Because it's still complex relationships and egos and all the rest of it that are normal working relationships. But
if you just say that there were egos on your board, I mean, that would be a shock to everybody on this podcast listening.
And I'm one of them, Matthew. So it's just the way it is. It took me a while to realise ego isn't a bad thing for some reason. But
as long as it's channeled in the right way.
Yes, yeah, and it isn't always, and I think that's the challenge, to be honest with you, isn't it? That is the challenge. But it's much better to be in amongst it, with the board, to be having those conversations, very much relying on your teams in the way I described earlier on, in their roles and their job design to be able to take it forward.
And so let's dig into this kind of clinical leadership role, because to begin with, you described this as representing the profession at the board, and the vast majority of the people employed in an ambulance world are going to be paramedics or people who are aspiring and training to be paramedics, because it's the job, it's the purpose of the organisation. I know that's simplistic, but I'm sure it's a high proportion. So just describe how you think you do that role in both representing, I guess, developing, but also, I guess, there's a lot of challenge in there, and there's a lot of standards issues in there, and I imagine lots of that revolves around you.
Yes, I suppose we might need to break that down a bit.
Yeah, do.
I could actually, Matthew. I suppose the first thing is, if I maybe just make that simpler and say, what is it I do that kind of addresses that? And I think, say 2.5 years ago when I joined NIAS, we were in a different place to where we are now, and when we're moving forward quite quickly with feature developments. And I think that as a profession, we've been fairly, so at NIAS, I think as a profession, we've been fairly static. We have ambulances and we have paramedics on ambulances. We have a small number of advanced practitioners who work in GP out of hours contracts and work across the Northeast in that way. But what I'd like to see us get to is, what is the role of the paramedic, and how do we start to play our part and lead in the wider system? So how does our profession develop into more advanced practice so that we can do more for our patients in the urgent emergency care space, so that they work alongside paramedics? They may be in a car, they may be targeted to the correct 999 calls where we know they can treat a discharge on scene because they're advanced practitioners. They can work in the emergency operations centre and do remote triage, which is actually very difficult. And we can start to develop practice, and the way we've seen in other professions, to start to have a greater impact. But also, how do we start to play our part in the system? And obviously, integrated neighbourhood health teams are big on the agenda right now. But how do we play our part in that? And in my view, rotate and have a portfolio working approach to rotating through those services and being part of their teams as well, because after all, we are referring to them and they don't know who we are, and we need to try and get that seamless pathway. And then how do those clinicians rotate back into our organisation, I think, with more clinical confidence, and are able to do more again as they continue to work in our area? that's an example of, I think, the vision, if you like, and the conversations that we are having at our exec management group as we think about the model going forward, and how are we going to change the service and develop it clinically and service delivery. And I think that that's not me. It is me, but it's my role being there that is enabling that, and that's happening, I think, in most ambulance services now, where a paramedic is on the board and able to have those conversations about the future direction of travel. I think that answers some of it.
Yeah. So a lot about shaping, as you say, the future, or the different ways we need our clinicians to operate with partners. So there's a kind of future approach in terms of what you do. I assume quite a big accountability for what the clinicians do day to day as well.
So that was the other part I was just thinking when you first asked that, because it does feel like it's around the clinical governance agenda within the organisation. So I work, as chief paramedic at NIAS. I work alongside a medical director who works 3 days a week. And I work alongside a director of quality and safety who is a nurse, because we're a foundation trust, and she has the patient safety and quality agenda. And together we take that wider collective quality and clinical practice agenda forward. My role, yes, is to represent the profession, but it's also heavily involved in the clinical governance side chair or clinical quality governance group. And that group is obviously the one that is the engine room and has the oversight of all of the clinical practice, the clinical effectiveness, patient experience, patient safety. So it in a way, the governance structure within NIAS that helps me to be accountable and to really think about the bigger picture about how we're pulling the threads together about what is the patient experience story telling us about patients' complaints and compliments of NIAS, what are the patient safety themes, and what are our clinical effectiveness measures looking like, and the softer stuff around, what are the things that are on our agenda or worry list, and the things we are working towards, that you try to bring together in a way to think about clinical, as you say, clinical standards and clinical effectiveness. So that's a really big agenda, and I think one of the things that I've noticed is I don't think people realise how big an agenda it is across the organisation or in certain quarters. And I think we're just starting to have those conversations about how much risk we're carrying, how big an agenda it is, and how much of a challenge it is. And it's a positive way. We've got a much better grip on clinical governance and safety, but it's a huge part of my role.
That triumvirate that you described, which is quality director, your chief nurse, medical director, you as director of paramedicine, and another clinical director, that therefore must be a really important set of relationships, because you can get structures for clinical governance, you can minute, you can meet, you can do all the levers out. But if you three aren't aligned, A, it confuses the staff, and B, I imagine it confuses the board and your colleagues as well. So what do you do to make sure that you three are joined at the hip, even if you presumably challenge each other and push each other and have those discussions about, are we doing this right, from all your different clinical perspectives? Give us a flavour of how that works.
The first thing I'll say is it hasn't been easy, Matthew, actually. It hasn't, actually. And there's loads of things I didn't expect, and it's been really interesting to go through this journey. And it hasn't been easy. So I think the first thing is that interprofessional relationship, and what do we all bring to the table? If I'm honest, that the chief paramedic is a new role. So we've suddenly started to occupy a space that was traditionally occupied by other professions. So how does that make everybody feel? And we've got to, kind of work with that. Probably back to the ego thing at the beginning as well. But we've had to work really hard at it, and it'll be an ongoing journey, I'm sure. But because the quality director is full-time, and, our nurse, but she's our patient safety and quality director, and I'm full-time, we tend to work together much more hand in hand together because the agenda is very, it's interlinked, so you can't really separate it. But because they're two very big agendas, we both bring our part to it. The medical director is crucial because we're not doctors. We're not experts in some parts of clinical practice. And while I think we can stand on our own 2 feet actually quite nicely, and I think we've proved that, there are things that we still absolutely, all professions still turn to medicine because they are the experts in certain areas. So we kind of work together as a triumvirate, as you say, to kind of take that wider piece together. But myself and the quality director will we really do it together, I think, in the main part. But it is very much a 3-role act. But I would say the other piece that we've not mentioned is operations in that. And so we've had some quite interesting discussions around, are we calling it right? Is it a triumvirate? Is it I can't even say the word quadrumphant. I don't like saying that word. What is it? And the label actually, I think, is unhelpful. I think I can see it when I was in a hospital. I could see that you had a nurse director, a medical director, and you had the operations, and it ran down quite neatly, didn't it, into the divisions and into specialties. But it doesn't work like that quite in the same way in an ambulance service, where we are one service that is geographically spread over a vast area. So it feels really important to work closely in that triumvirate way you said, but actually you can't do it without the ops director as well, and how anything we're doing is translated into operational practice. So all those conversations have to be happening at the same time. So how you do that, I think, is key, because you have to be constantly talking to each other as a team at the same time and individually with each other to land on the same page, to have that debate, to try to get to a place where you agree. Some things you agree from the outset, other things you don't, and try to go forward then collectively with an agenda. And I think a good example right now is, as you know, the planning round is out. There's loads of activity around that. But what does that look like for our model? What are we going to do going forward? And what is the impact on, finance and performance, etc.? That's taken a lot of discussion right now at this time of year.
Fascinating. And help us to just shed some light on that a bit more then. So obviously not on your internal dynamics with your fellow directors, that's what you can do. But if I kind of step back and think about what we're all strategically trying to do, and you've mentioned the word a few times, I think it's probably making sure that we make good risk-taking decisions to support people to be well at home for as long as possible, and only revert to ambulances, 999 services, and acute apparatus and infrastructure when we desperately need it, but actually alter that. And that is a risk-taking. It's a different appetite. It's a different culture, and it comes with a whole background of things that need to alter to allow that to happen. And you must be at the heart of some of those things to drive that, both with your paramedic workforce, but also with your GPs, your community workforce in the local area, to actually say we're forever pushing the risk appetite up and up, but doing it safely. Give us, as a really important clinical leader in that space, though, how do you actually do that? Because all this sounds really simple to say. It's really hard to do, isn't it?
Well, once you said it, you started to overwhelm me, because it's so big, isn't it? It's absolutely huge, and it's not easy. I think one of the things I've been doing more recently to try to think about what's my role in this shifting agenda as an organisation that is part of a system that is shifting in the way you described, to try to do the right thing for our patients. It's not just left shift, as we call it. It's about keeping the right people in their homes and the risk taken that comes with that, but also recognising the right people that need to go to hospital, and then the right parts of the hospital, etc. I don't want us to take our eye off the ball of acute and emergency care at the cost of just talking about admission avoidance. So one of the things I've done more recently is to think about who are our populations that we serve across the Northeast. Because if we don't know that, we won't know our service model, we won't know our clinical strategy going forward, we won't really know what our priorities are. We just think we do, and we think, yeah, we'll do more left shift and we'll respond to patients, and we think there's a mental health problem going on, but the data doesn't really support or isn't traditionally there for us. So we've worked over the past year to work with communities through community engagement, Health Watch, an organisation as well called VON, who have contacted hundreds, I think thousands actually, of our communities and asked them what's important to them. We've gone out and met them, we've had those discussions to understand their needs and what they want from an ambulance service. And it isn't what I thought we thought it was. So we are at risk sometimes of saying they just want an ambulance quick and they want to go to hospital where they'll be cared for. You do hear that, but you also hear, I live in a rural area and I don't want to go a long way to a hospital to not necessarily get the care that I could have had at home. So I'm prepared to wait longer for the right model and the right professional to come and help me. That changes our conversation for what do we need to do to help those people. And then we've worked with an organisation called NEX, who was part of the NHS, to help us with population data, to understand the backgrounds of the people in the Northeast and understand the conditions, the background, the demographics, and the long-term conditions of the people who contact 999 and 111 in the Northeast, which helps us to get a bit of a flavour of the background morbidities of people who are calling us. And then we've worked to develop the data of why people call 999 and 111 to understand what our clinical priorities are. And that helps us to shift, I think, what our focus should be in the future. So yes, actually, it should be left shift. We've heard that people want to be cared for in the community. They don't want to go to hospital inappropriately. But we also know they have long-term conditions that can be managed in the community, as the data's telling us. But we also know from the data that people call 999 in an order of priority in terms of the volume. The top one is cardiac problems. The second one is respiratory. The third one is medical, of which it's healthcare professional admissions, which I think is interesting in itself. The fourth one is stroke. And the fifth one's mental health. Sixth is falls. That is going to change over time. That is going to, as over the next 10 years, going to shift. I have a funny feeling from the data, the early data we're seeing, that falls and mental health will increase and start to go up that priority order. Again, that'll shift what we will be doing, how we respond to patients. So that's just a long-winded, sorry, Matthew, example of trying to describe what I think my role is clinically, the lens I'm bringing and how I'm thinking about how do we think about the service we deliver for our patients, and how do we make sure it's evidence-based, not just us saying what we think is best. And that's already shifted our conversations as a board and as an organisation about what's our future strategy and model. That then, actually, sorry.
And I presume, Andrew, that then turns into your role as a clinical director, board director, is then to talk about, actually, is our model right? Are we strategically as an organisation, have we got this correct? Do we need to alter? Do we need to change our board risk appetite? As those are conversations that have flown out of that analysis and understanding.
Yes, and actually, I would say that that probably even before that, I don't think we were having those conversations. I think my role has been to bring that analysis and question to the table, then bring the data. People have suddenly saw that. They've heard me saying it, but they haven't felt what I've felt because it's not their world, which is fine. But once I brought it, they've thought, I see what you're talking about. And then it's led to the next conversation about, well, what are we going to do about it? How does that affect our service model and our clinical priorities? It's been a really positive thing. But yes, it does help to, I think, change the clinical model. What we'll then do is we'll start to talk about that in the system, and that feels really important as well. So I've already started to reach out to some public health directors actually to have conversations about, because some of it's so complex we can't do it on our own. I know what I can now see what we need to do, but the population health stuff in particular, I want to go and talk to public health directors and say, what does this mean to you? Just help me understand this a bit more. What does it look like from your lens? And then I think we can start to bring those conversations further and further out, into the urgent emergency care space, community space, and in system conversations to then, I think, just to explore it and try and get the so what from it.
That's really interesting because it's a practical kind of schematic of A, changing, but B, understanding where, frankly, the parameters and the extent of what you can actually do, and you need other people to do it. I mean, we all know that the vast majority of things that impact on people's health are things that the NHS doesn't do. It's housing, it's people's education, it's people's having a job, and et cetera, et cetera. It's having green spaces. So I guess that's the impact, but it's doing it with a razor sharp focus on the data and knowing your point of knowing your populations. And actually, if you want to make a difference, you're probably not going to change the amount of strokes very quickly, but you could make a difference on how many falls are happening that need a paramedic intervention.
Really, but the point actually that I've realised and the conversations we're now having is that's right. We are our fourth greatest reason for calling 999 is stroke, and that's important to know that, because that actually means let's start working with the stroke networks with a greater focus. Let's think about how do we get those people to the right place of care quicker, sooner. Every minute equals time, and it reduces disability, mobility. People can get back to work in the community, etc. So that's why I keep saying, actually, this isn't just about admission avoidance, caring for people in the community. It's about all of it. And now we understand that. I think that means we're going to be able to focus on the most important things.
Yeah. And socioeconomic factors, a whole bunch of things we know play a big part in how people then manifest in those illnesses, aren't they? So tell us how people experience you as a director of paramedic. What's the leadership style and approach and the impact on your culture as an organization of you doing your role, Andrew? This is not an appraisal, by the way. This is
I've written it down. It's okay. I did an appraisal last week, so no. I actually think this has been a really fascinating part for me over the past 2.5 years, because as you'll know yourself, you kind of have to really dig deep and look into who you are as a person, as part of your development, but actually as part of the team development. It's been a really important journey for a set of directors, a team of directors, to know each other very closely, to understand what makes each other tick, what are our vulnerabilities, what are our triggers, to really kind of know how to work together in a more solid way. And that's been something we've done with quite a focus over the past few years. But for my part, I know what I'm like as a person, and we hear about these colours, don't we? So I'm a green blue. I've been labelled a green and a blue, and that means, and it fits perfectly. It means I am very much a people person. I'm about relationships. I'm the blue bit, by the way, is data. You can tell from the conversation just earlier on, I'm right into that. But the green bit is more important to me in my role, in the sense that I'm very much a people person. I try to help others. I make sure that people are at the centre, and that feels really important in clinical leadership. And it's something I noticed years ago when a paramedic was really frustrated and called me. I'd never heard of her before, but she started to email me, and then we arranged a quick phone call when I was somewhere. And I can remember saying to her, I'm really sorry, it took me about 2 weeks to reply to your email, but here we are having this conversation. And she was basically saying, I'm so grateful you actually did reply, because most people don't. Or and I suddenly realized it's just giving people your time and being there for them that matters more to them. And so that is kind of the part I play, and it's not a deliberate choice, and it's who I am. And if we have another colour, somebody's a red, and they're red for a reason, and that's a good thing as well. and it kind of it's the important stuff to me. So if I also think about who are my role models in the past, they are the people that actually were authentic, they cared for others, they took time out for you, they helped you to develop. They then role modeled and inspired you, and you wanted to do more for them anyways, you know. So it's kind of what I've realized is the things that are important to me are the things that I've experienced as well. When it's gone well, it's had a huge impact. Those that haven't been so good also have had a huge impact, and it steers me away from that as well. So, yeah, I think that kind of might describe it a bit, Matthew, without going on.
And help people, because the ambulance world, the paramedic world has had some real challenges in some parts of the country, haven't it, about its identity, its purpose, and its culture. And lots of organisations have worked really hard to do that, because my sense is, and I'm sitting here in Cambridgeshire doing this, only a few weeks ago there was the terrible knife attack on the train, and the paramedics were there when there was probably someone running around with a knife. So they were in there in a really tough situation, with police around, with guns out, and it would have been absolutely manic. As then at the same time, they could be the next day out seeing a very frail older person who hasn't seen anybody for weeks, and next they're on to someone having a mental health crisis. And that is an amazing amount of skills and attitude to do. And you're a clinical leader of people who are traversing all of those things all the time. I'd say that's pretty tough, isn't it?
Yeah, even when you say that out loud, it actually does feel tough, and that's actually something it makes me really proud for the profession, to be honest with you. But then I cast my mind back into full-time clinical practice and how that made me feel that every day I was going to falls, chest pains, things that I was comfortable with, but I had something hanging over my head. The longer I went without it, the more it hung over my head. I haven't had a bad road accident for a while. I haven't had that cardiac arrest for a while. And that's something you almost kind of live with, and kind of it's just hanging there, and you're waiting for the next bad job, that may have an impact on you, and you don't know what that impact's going to be. It might be life-changing, it might not. And so that's I've just described the human side there. You discussed the skill side, but I think that human side actually is the first thing that jumps out to me when you say that.
Yeah, and your clinical director role is both, I guess, setting the framework, setting the ingredients with your operational teams to be able to manage all of those things, which must be pretty hard emotionally as well as physically on your staff, as well as help people to think about. But at the same time, as you said earlier, we need to do things differently to give people the right outcomes as well. Yeah. And is that then hitting into the nub of where the board role becomes tough, because you're balancing all those things all the time?
Yeah, it is. And I think that's the key bit, that you have to work as a team. So some of those things you're describing, you can't, this is not down to me. I'm the paramedic voice in a way in some of these things, and I'm giving that lens. But we have an operational director, PM, some of the things you've just described. You have a chief people officer who really leads on that well-being piece, all of that sort of stuff, the culture piece as well. But we're all doing it together and how we work together as a team. But yeah, I'm bringing that clinical lens and them clinical stories in a way that bring it to life. And you could almost say it's a sense check as well, couldn't you? Like, does this work on the ground? And I'm not on the ground all the time, but I still have memories, feelings, emotions that can be triggered in a way we've just been talking about, that brings that story into the plans and the debates, and the strategy sessions, even about which way we're going to go forward in that complex scene that you just set, that ranges from care for frail, complex elderly people to a stabbing on a train, which must have been horrendous for those people and those clinicians that responded.
Yeah. So let's, into the last section, talk about what keeps you sustained as a leader. So as a clinical leader, how do you I guess I don't know. How do you find the energy? How do you find that enthusiasm? How do you? I know you've talked about the responsibilities of the board with your colleagues to do things, but how do you do that? What's important for you as a clinical leader to be able to carry on doing this and do it well?
Well, sometimes I ask myself that, Matthew, as well. How do we have the energy to do these roles that literally can consume your life? And like very few people work 9 to 5 roles. It's not to say that a director is special, but because I'm accountable and because I will have to sit at board or sit with my exec colleagues, you have to put in the time and effort to make it right, no matter how much time that takes. And that can be very, very draining mentally and physically. And I guess, if I'm being honest, right now, and for the past year, I've really thought about what impact is that having on me, and how do I try to sustain myself, what's important to me personally, and how do I even carve out the time to do something that is a me thing. And then even that sounds draining sometimes. So it's quite difficult trying to do that. But I think what sustains me is actually trying to keep that in focus, what's important to me personally. The things that we do in our own personal lives that are important to us, but which allows you to bring your whole self to work. I've got to try and keep that in focus. That dips up and down quite often. That's a struggle. A lot of people will recognize that. But I also think having a vision, I touched before as well on role modeling and those people who are important to me in the past, who had a greater impact on me. It's how you've been shaped over the course of your career and the things you hold on to that I think help to sustain, for me personally, helped me sustain me doing my role going forward. So literally there are only two people that jump out in my head in 30 years who are exceptional, but they will never leave me. And I know what they did. I know how they behaved. Actually, it's more how they behaved than what they did. It's how they were around you that helps me to sustain going forward, because that makes me want to be like that as well. It makes me want to do that for others and act in the same way. So I think that helps me kind of sustain it, keep going, and enjoy what I do.
And as you're talking, it kind of brings to mind a couple of things. Elite sportsmen and women talk about muscle memory, i.e. they do all the things regularly, so when they actually need to do it, the muscles are ready. I'm out of my depth, of course, at this point, but they're ready to do those things, and it's normal. And you're almost talking about the equivalent for leadership is you've built up that reserve and knowledge over time and time and time, and actually what you're doing is topping it up and building on it. And you've had really good info. Those two people have been fabulous influences on you. And I think I remember recently talking to the aspiring chief executive world, their course, and really great two sets of cohorts. And we were talking about being a chief executive. And I on that point, I made the point to them is, just become a chief executive does not then suddenly make you change. You have got to build up your approach of working, and then all you're doing is stretching yourself into a new role. You don't suddenly become a new leader because of a title. And I'm getting that sense from you. This is a gradation of responsibility, knowledge, and experience that's culminating in what you're doing now.
Yeah, absolutely. I think that's why I said at the very beginning, I've not just stayed in ambulance service, and it was not deliberate, but I'm grateful reflecting back on it now. It wasn't deliberate at all, but I'm grateful for all of the experiences, even though at the time I couldn't stand some of it. I was bored by some of it. I remember thinking, do I really need to be in an office in my late 20s? This is awful, watching the ambulances go by. But looking back, that was perfect.
Yeah.
They were really good experiences. And you're right, they do help you to shape going forward, and then kind of know who you are, I suppose.
Yeah. So, final question, Andrew. What are you looking forward to professionally, quickly? And you've mentioned some things in there because you're doing lots of forward thinking. But if you could knuckle down to kind of one thing, what's going to excite you for the kind of coming year? You think, I want to knock that out the park.
I probably did like that pat on the back earlier on, didn't I? too early. But I think it is the role of the paramedic profession and how we are going to grow into a much wider space than where we've been traditionally. And I say traditionally very loose sense that, we've been doing this for years, moving into other spaces. We work in primary care as paramedics, we work in prisons, we work in private healthcare, we work in hospitals as ACPs. And we increasingly work in mental health in a small way, but we're growing in that space. And what excites me and what I want to see us do is to continue to do that, grow in numbers, grow in capability, and have that flexibility, more flexibility, because you just described it before, be more flexible in more spaces and be able to go into different settings where I think there's a need for it. I think my own experience over the years has been multi-professional working. That is much better. And I think if we can do that going forward as part of an integrated neighbourhood health team at place, as part of some urgent care response or care coordination hub, that would be really good for our profession, but it actually would really help us help the system and patients and partners much easier as well.
Andrew, it's been fascinating listening to you, and I'm sure those who are listening on now will agree. 2.5 years into your director of paramedicine, 30 years in the NHS, that kind of move from into other roles, advanced practice, consultant roles, leading AHPs, now doing the board role, that triumvirate responsibility, that bringing of research, data, balancing risk, working with everybody else and trying to implement change. And then just that whole point of actually doing it with the right style, learning, developing, being that human change and actually wanting what's best for the paramedic workforce and into kind of 10-year plan territory, that it's going to be really important, has just been fascinating. And it's great to hear a clinical leader so enthusiastic about both a profession, but also the work that profession does in its broadest sense. So, Andrew, thank you so much for joining me on leadership and culture in healthcare. It's been wonderful to talk to you and hear different insights from a clinical leader. Thank you so much.
Thank you, Matthew. It's been fun.